All right, so we've got some listener mail about a 69-year-old man. Seems like he's dealing with some pretty worrying symptoms.
Oh, yeah.
Yeah, we're talking blood in the urine, but no pain, which is odd. He's lost weight, too. Quite a bit, actually.
How much are we talking?
7 kilos over just 4 months. And to top it off, he's got a history of smoking, like a serious smoker.
Okay, starting to get a clearer picture here.
And get this, he spent 25 years working in a chemical factory. So, quite a bit to unpack here, huh?
Lots to consider for sure. Where do we even begin? Well, I guess with the symptoms you mentioned, frank hematuria and it's painless, that's significant. And then the weight loss on top of that. In a patient this age, yeah, got to consider a malignancy.
Like right away.
Pretty much, especially with the smoking history and that chemical factory work. Bladder cancer definitely has to be on the table.
Makes sense, I guess. But why bladder cancer specifically?
Well, you think about it, 80 pack years of smoking, that's huge risk factor right there. And then the chemical exposure for 25 years.
Yeah, adds up.
Exactly. Plus, when you look at how bladder cancer usually shows up, almost 90% of patients have blood in their urine. So in this case, it's got to be high on our list of possibilities, our differential diagnosis.
Okay, yeah, I get it. But I'm sure it's not the only thing we should be thinking about, right?
Absolutely. We got to consider other things too. Renal cell carcinoma, kidney cancer, in other words, could also be a culprit. Not as common as bladder cancer, but age and smoking make it more likely.
I see.
We need to dig a little deeper into his history, do a thorough exam to really see if it fits.
Okay, so bladder cancer and kidney cancer are the main players. What about other stuff like prostate problems or bladder stones? Could they be the reason for the blood?
It's possible, but less likely, I'd say. Those usually show up as microscopic hematuria. You need a microscope to see the blood. Our guy here, he's got what we call frank hematuria. You can see the blood without any fancy equipment.
Ah, so the type of blood makes a difference.
Big time. Plus, that weight loss, 7 kilos in 4 months, that's pretty drastic. Doesn't really point to something simple like bladder stones or a prostate issue.
Okay, that makes sense. So what about a bladder infection?
Less likely, I think. We don't see the usual symptoms like burning when he pees or needing to go all the time. And again, that weight loss is a red flag. Doesn't really fit with a simple infection.
All right, so we've got our main suspects, bladder cancer leading the pack, kidney cancer trailing behind, and those other possibilities are less likely. So let's say this guy walks into a doctor's office. What happens next? Walk me through the exam.
First things first, patient safety. Always got to follow the ABCDE protocol.
Right, the basics.
Airway, breathing, circulation, disability, exposure. Got to make sure he's stable, hasn't lost too much blood. No immediate danger.
Right, safety first.
Exactly. Then we get to the physical exam. We'd be checking for any lumps or bumps in his abdomen, especially around the bladder area. And, of course, a digital rectal exam to feel the prostate. Got to make sure that's not enlarged or anything. We'd also check his bladder, feel it to see if it's distended.
Distended, what would that mean?
Well, it could mean there's something blocking the flow of urine, could be blood clots, maybe even a tumor blocking the urethra.
Oh, I see. So the physical exam itself can tell us a lot already.
Absolutely. But we can't stop there. We need to do some investigations to really get to the bottom of this. First up, a urine dipstick test. Simple and quick, just to confirm the blood is actually there.
Makes sense.
Then we need to look at the urine under a microscope. That'll tell us if there's an infection and if we can spot any malignant cells.
So the urine holds a lot of clues.
Tons. And then we move on to imaging studies.
Like what?
A CT scan is usually the first step, a CT KUB to be specific. Gives us a good look at the kidneys, ureters, and bladder. Can spot stones, any other structural issues.
Makes sense. Get a clear picture of the whole urinary tract.
Exactly. And sometimes we do an IVU, an intravenous urogram. It's another imaging test, but this one uses a special dye to highlight the urinary system.
Ah, so it's like a roadmap of the urinary system.
Exactly. Then there's ultrasonography. That one lets us look at the renal parenchyma, the working part of the kidneys, to see if there's any masses or anything unusual.
Okay, so lots of different ways to see what's going on inside. But what about getting a direct look inside the bladder itself? Is that even possible?
Oh, absolutely. That's where cystoscopy comes in. It's considered the gold standard for evaluating the bladder.
So they can actually see inside?
Yep, with a tiny camera, it lets the doctor see the bladder lining, check for tumors or any other weird stuff.
So it's like a tiny submarine exploring the bladder.
Kind of, yeah. And if they see anything suspicious, they can take a biopsy right then and there.
Wow, that's pretty amazing. So what kind of cystoscopy would they do in this case?
It could be either flexible or rigid, depends on what the doctor thinks is going on and what they prefer. Flexible is more comfy for the patient, but rigid gives a better view and lets them do more stuff, like taking those biopsies.
Okay, so lots of options depending on the situation. So let's say they do this cystoscopy and bam, they find a tumor. What happens next?
Well, then the real detective work begins. We got to figure out how bad it is, the stage and grade of the cancer.
Right, we talked about stages earlier.
Yep. That's where more imaging comes in, usually a CT scan of the abdomen and pelvis, got to see if it's spread beyond the bladder. And they'll take a biopsy of the tumor to see what type of cancer cells we're dealing with, how aggressive they are.
It's like gathering intel, figuring out the enemy's position and strength.
Exactly. And the whole time, it's not just one doctor calling the shots. This guy would have a whole team on his case, a multidisciplinary team, or MDT for short. Urologists, oncologists, radiologists, pathologists, nurses, you name it.
Wow, a whole army of experts.
That's right. They all work together to come up with the best plan, tailored specifically for him.
Okay, that's reassuring. So it's not just one doctor making all the decisions.
Not at all. This MDT approach makes sure he's getting the best possible care, taking everything into account.
That's great to hear. This is already so insightful, really getting a sense of the complexity of this case.
It's a wild ride, this world of urological health.
Tell me about it. I'm hooked already. So now we've got a diagnosis, or at least a strong suspicion. Where do we go from here?
When we talk about bladder cancer, this whole staging system, it can seem like a whole other language.
Yeah, it's pretty complicated stuff. We mentioned it before, but can we break it down a bit more? Like, what does it actually mean for the patient?
Sure. So bladder cancer staging uses what we call the TNM system. It stands for tumor node metastasis. Basically tells us how far the cancer has spread.
Okay, I've heard that term before, but how does it work specifically for bladder cancer?
So let's start with the earliest stage. We call it stage 0A, or non-invasive papillary carcinoma. At this stage, the cancer cells are just hanging out in the lining of the bladder, the urothelium. They haven't gone deeper into the connective tissue or muscle, no spread to the lymph nodes or other organs either.
So it's very localized.
Exactly. Now, if we move on to stage 1, the cancer has started to dig a bit deeper into the connective tissue below the lining, but it still hasn't reached the muscle of the bladder wall. Again, no lymph nodes or distant spread at this point.
Still contained, but getting a little more aggressive. So what happens when it does reach the muscle?
That's when we bump it up to stage 2. We divide that further into IIA and IIB, depending on how deep it's gone into the muscle. Key thing here is it hasn't busted through the muscle into the surrounding fat or anything. And again, no lymph nodes or distant spread.
Got it. So up to this point, we're still talking of cancer that's confined to the bladder itself. What happens when it breaks out of that shell?
That's when things get trickier. Stage 3. This is where the cancer has spread beyond the bladder muscle. It's in the surrounding fat, maybe even poking into nearby organs like the prostate, the uterus, or the vagina. But, and this is important, it hasn't spread to the pelvic or abdominal walls or the lymph nodes, and no distant spread yet either.
So still somewhat localized, but treatment is getting more complex, I imagine.
Exactly. And then we have stage 4, the most advanced stage. We split this into IVA and IVB. In IVA, the cancer has broken through the bladder wall into the pelvic or abdominal wall, but it hasn't spread to lymph nodes or other organs. But with IV, we're talking about cancer that's spread to the lymph nodes or further afield, to places like the lungs, liver, or bones.
Wow. Okay, so a lot of different scenarios within each stage. I can definitely see why understanding the stage is so important for figuring out the right treatment.
It's crucial, really. This TNM system helps doctors talk about the cancer in a standardized way, makes it easier to decide on the best treatment and predict how the patient will do.
Speaking of treatment, you mentioned earlier that certain jobs can increase the risk of bladder cancer. Can we talk about those a bit more?
Right, we were talking about that chemical factory our patient worked in for 25 years. There are definitely some industries where workers are more likely to get bladder cancer.
Like what kind of jobs specifically?
Well, the textile industry is a big one. Exposure to aromatic amines, that's a major risk factor. Then you've got rubber manufacturing, paint production, leather working. Basically, any job where you're around certain chemicals for a long time can increase your risk.
So it's not just working in a chemical factory, but it's the specific chemicals you're exposed to that make the difference.
Exactly. And it's not just the type of chemical either. The amount of exposure you get, how long you're exposed, that matters too. The longer you work with these carcinogens and the more you're exposed to, the higher your chances of getting bladder cancer.
So kind of like a cumulative effect.
Hmm.
Aside from knowing about these job risks, what can people do to lower their chances of getting bladder cancer?
Well, first and foremost, if you smoke, quit. If you don't smoke, don't start. Smoking is a huge risk factor. Staying at a healthy weight and eating a balanced diet, lots of fruits and veggies, that helps too. And of course, early detection is key. Know the symptoms, and if you notice anything different, like blood in your urine, get it checked out right away.
Solid advice. Smart choices and staying vigilant. That's what it's all about.
It really can make all the difference. And even though we've been focusing on bladder cancer, we can't forget that blood in the urine can be a sign of other things too. So if you see blood, whether it hurts or not, whether it's a lot or just a tiny bit, get it checked out. You never know.
Good point. It's not always cancer, but it's always worth getting checked out.
Exactly. Better safe than sorry.
I totally agree. This has been super informative, really getting a deeper understanding of this whole hematuria thing, all the possible causes, and especially all the details about bladder cancer.
Glad to hear it. It's amazing, isn't it, how something like blood in the urine and some weight loss can point to something much bigger going on. It shows how our bodies try to tell us when something's wrong. And we gotta listen, right? Get that medical advice when things feel off.
I couldn't have said it better myself.
We've covered a lot of ground today. We talked about the staging system, the different types, the different scenarios.
Yeah, we've laid the groundwork for sure. But now we need to talk about the actual treatment for bladder cancer.
Exactly. So stay tuned. We'll be back with part 3 of our deep dive, where we unpack all the different ways to treat this complex disease.
All right, we're back, ready to tackle the final part of this case. We've talked about symptoms, possible diagnoses, that whole staging system for bladder cancer. Now let's talk about how we actually manage bladder cancer.
Right, treatment for bladder cancer. It's not a one-size-fits-all kind of thing. Got to consider a lot of factors.
Like what?
Well, the stage and grade of the tumor, obviously, and the patient's overall health, what they want, what they're comfortable with, and of course, the expertise of the whole team managing the case.
Right, that multidisciplinary team we talked about. So we've got these different stages, from the early ones where it hasn't spread to the more advanced ones. What are the main treatment options? Like, where do we even start?
Okay, so for those early stage tumors, the ones that haven't invaded the muscle, like that stage 0E we discussed, the go-to treatment is TUR-EB.
TUR-BT. What's that stand for?
Transurethral resection of the bladder tumor. Sounds scarier than it is.
So what happens during a TUR-BT?
Basically, it's a minimally invasive procedure. They insert a special instrument, a resectoscope, through the urethra into the bladder. This resectoscope has a tiny wire loop that cuts away the tumor.
Ah, so no big surgery for these early cases.
Nope, TUR-BT is usually done under general or spinal anesthesia. Patients often go home the same day or after a short stay in the hospital.
That's good to hear. But I'm guessing there's still some follow-up after a TUR-BT, right?
Oh, absolutely. After a TUR-BT, patients usually need regular cystoscopy checkups. Got to keep an eye out for any signs of recurrence.
So they remove the tumor and then watch closely to make sure it doesn't come back.
Yeah.
Makes sense. Now, what about those more aggressive tumors, the ones that have grown into the bladder wall? How do you treat those?
Things get a bit more complicated then. They might still do a TUR-BT to remove as much of the tumor as possible, but usually it's followed by something more, like chemo or radiation.
Chemo for bladder cancer. I don't know much about that.
Yeah, chemo is a big part of treating invasive bladder cancer. There are a couple of ways to give it. One is intravesical chemo, where they put the drugs directly into the bladder through a catheter.
Okay.
The other way is systemic chemo. That's where the drugs are given intravenously, so they go throughout the whole body.
So the method depends on the specific case.
Exactly. The team looks at things like the stage and grade of the tumor, the patient's overall health, any other medical issues they might have. All of that goes into deciding the best way to give the chemo.
Sounds like there's a lot of individual tailoring involved in these treatment plans.
There is, for sure. And then there's radiation therapy. We haven't even talked about that yet. That can also be used to kill those cancer cells in the bladder.
Right. You mentioned that earlier. So we've got surgery, chemo, and radiation. When would they use radiation?
Sometimes it's the main treatment for early bladder cancer, especially if the patient can't have surgery for some reason, or they might use it along with surgery or chemo for those more advanced cancers.
So there's a whole arsenal of weapons to fight this thing, depending on the situation. We also talked before about how sometimes they have to remove part or even all of the bladder. That sounds pretty intense.
It is a major surgery. We call it a cystectomy. They usually only do it if the tumor can't be treated with other therapies or if it's spread beyond the bladder wall. There's partial cystectomy, where they just take out the part of the bladder with the tumor. And then there's radical cystectomy, where they remove the whole bladder.
Wow. I can't imagine what that's like for the patient. So if they take out the bladder, how do you get rid of urine?
That's where urinary diversion comes in. Basically, they have to create a new way for urine to leave the body since the bladder's gone. There are a few ways to do it, but the most common are the ileal conduit and the continent urinary diversion.
Those sound pretty different. What's the difference?
With an ileal conduit, they use a piece of the small intestine to make a tube, a conduit, that connects the ureters, those tubes that carry urine from the kidneys, to an opening on the belly, a stoma. Urine constantly drains from the stoma into a bag that the patient wears outside.
Ah, so that's what those external pouches are for.
Exactly. Now, a continent urinary diversion is different. They create a pouch inside the body using part of the intestine to hold the urine. Then the patient uses a catheter to empty the pouch a few times a day.
So it's like an internal bladder, sort of.
You could say that.
There you
It
go.
gives them more control over urination than the ileal conduit, and no need for that external bag.
That sounds like a better option, if it's possible.
It can be, but it's not right for everyone. The choice depends on a lot of things: the patient's health, what they prefer, the surgeon's experience, the specifics of the cancer. It's a team decision.
It seems like there are a lot of tough choices when it comes to treating bladder cancer. Must be a lot to handle for the patient and their family.
It definitely can be. That's why the multidisciplinary team is so important. They help guide the patient through it all, explain the options, answer questions, address concerns. It's about helping the patient make the best decision for themselves.
That's good to know. It's not just about treating the disease, it's about supporting the whole person.
Exactly. It's about the physical, emotional, and social needs of each patient, making sure they have what they need to get through this.
Well said. This has been an incredible deep dive into bladder cancer. We've learned so much about the symptoms, diagnosis, treatment options, and the importance of a team approach.
It's been my pleasure. And remember, knowledge is power. The more you know about your health, the better you can advocate for yourself. Ask questions. Talk to your doctor. Don't be afraid to seek guidance.
Great advice. And with that, we'll wrap up this episode of The Deep Dive. Until next time, stay curious and keep exploring.